This meeting is being recorded. Hello and welcome to Webinar Wednesday. I'm Dr. Pebbles Turbyville. I'm the CEO for Horses and Humans Research Foundation. And just to give you a little intro, HHRF is all about horse and human interaction, exploring it, educating others about the value and the relationship and the connection. And we also support research that helps both thrive. So this is our webinar series, and I'm going to turn it over to Dr. Deborah Thompson, our board member, and to be the host for today.
Thank you, Pebbles, and welcome everyone to our webinar Wednesday. We're so excited to have you with us today. And I'm very excited to welcome our speaker for today, Dr. Beverley Kane. She is Adjunct Clinical Assistant and Professor of Medicine in the Stanford Division of Primary Care and Population Health. Today's webinar is Methods, Rationality, and Phenomenology. I can't even talk this morning, excuse me. Phenomenology in medical research. So Western and alternative methodologies for complex multi-component interventions such as equine-assisted learning and therapies. Please welcome Dr. Beverley Kane.
Thank you, Deborah and Pebbles. Thanks for having me. I'm going to start my presentation, which is what we call in Silicon Valley death by PowerPoint, but it seems like an okay medium. With that said, we decided that we can probably take some interactive, interrupting questions during the presentation in chat. Deborah will be monitoring chat, and especially if it's a question about something that's not clear, and the clarifying answer can be relatively short without getting into a long discussion down the rabbit hole into the weeds, then we can take your questions. It's a small group, so that should work, and at the end we'll certainly have time. So I'm going to share my screen. Let's see. Nope. Can you all see that?
Yes, thank you.
Do I hear yes? Thank you. So the going in proposition here was for me to talk about research methodologies, but then Pebbles really wanted to hear about the exact work that I do. And since we do have practitioners here, I've created a loosely connected segue between the two, and hopefully that all makes sense. So as Deborah said, I am on the faculty in the Department of Medicine at Stanford. I've been at Stanford off and on for 38 years, and my private practice is Horse Sensei Equine-Assisted Learning and Therapy, and that was founded in 2003. And Horse Sensei contracts with Stanford for some of our classes, whereas others are right directly Stanford. So I need to adjust my panel here because I can't see. I can't see the titles. Okay, so let me tell you a little bit about the Stanford programs. The earliest program was a program called Medicine and Horsemanship. It was designed for medical students, and the subtitle, which is also the title of the manual that I wrote, is called Transforming the Doctor-Patient Relationship with Equine-Assisted Learning. So it teaches communication, teamwork, leadership, and self-care, designed for medical students and PA students and nursing students. However, because I can't control who registers for the class initially, we've had engineering students, law students, business students, and undergraduates. So we're now in our 21st year. We've played with different formats. We've had a couple of hours a week for 10 weeks of the quarter, and that didn't fly. So what we've settled on is 2 full Sundays in the spring, and that seems to be the easiest for everybody concerned, especially the medical students. So the activities with the horses simulate clinical scenarios. We have the first 3 seconds in the exam room is a meet and greet activity because most of these students will never have been around horses. So we do our safety talk and our petting and our just kind of getting to know you in that activity. We simulate respectful examination of the patient. The most popular segment of medicine and horsemanship is when we have an equine veterinarian teach the students how to listen to the horse's heart and lungs and gut sounds, and the students just love that. Absolutely the runaway most appreciated segment. One of our activities simulates teamwork in critical care areas. There's a really fun exercise that involves asking the horses to go over through a scary obstacle so that students become really sensitive to addressing patient fears. Actually, we call that exercise uninformed consent. And I've written a manual to go with the class, which with the idea that people could replicate the Stanford program. And in fact, that's happened with several medical centers and equine-assisted learning practices, and that's been very gratifying. So my favorite program is Equine-imity Somatic Horsemanship. Subtitle, is this the subtitle? Yeah, stress reduction and emotional self-regulation in the company of horses. And this is given directly through Stanford Medicine. Actually, no, this is a horse sensei program contracted with Stanford. It's a little complex, the administrative details, but this came about because the head of the health improvement program, who had horses growing up, watched the meditation ride for medicine and horsemanship, and we thought it would be a great stress reduction program for Stanford employees. And there'll be a little bit more on that later. So next year, oh, I'm sorry, I should say 2026. 2026 will be our 10th year. The format is it's a 4-week class. It meets for 1.5 hours the first 3 weeks, and the last class, which is a meditation ride, is a 2-hour class. The basis of equanimity is qigong. Qigong is a kind of gentler form of taiji, which is a martial art. It's more relaxing, and it doesn't move around as much. It's not as ballistic as Tai Chi tends to get. Tai Chi, as I also teach it. So it says so most of the sessions are on the ground, and then the last week people can optionally ride. We don't make we don't ask people to ride. We use a therapeutic riding configuration where one person leads the horse, one person rides, and there are optionally 1 or 2 sidewalkers for support. And we emphasize that people will be an important part of the team, even if they opt not to ride. I think in the 10 years I've been doing this, there's only one person that didn't ride. And I think even she got on finally, eventually. So I've written 2 books. The Equanimity was actually written for non-horsey, non-meditating people, but the people who bought it were basically horsey meditators. And the Manual of Somatic Horsemanship, which is relatively new, was uh, kind of written and co-written by a group of us from the Somatic Horsemanship Association International group on Facebook, and people who have been colleagues for many years. So there's a chapter on yoga and horsemanship, EMDR, eye movement desensitization and reprocessing, somatic experiencing, and taiji and horsemanship. So for both medicine and horsemanship and equanimity, the last activity is what we call a therapeutic ride for medicine and horsemanship, and a meditation ride for equanimity. Just kind of fits the language of each of those programs. As I said, we use a therapeutic riding configuration, and we ride to this Tibetan and Native American flute music.
Beverly, we've lost your sound. Oh, there it goes.
Oh, well, I was just playing music. Did you not hear the music?
I think as I spoke, it briefly popped in.
Did anybody hear the music?
No.
Nobody heard the music? Okay, well, that didn't work. Okay. So on campus, without horses, I also teach medical Tai Chi. We're in our 17th year, 36th quarter, starting today at 4 o'clock. It's a 10-week program corresponding to the Stanford academic quarter. It consists of qigong and tai chi practice. And we also have a journal club. It's called Medical Tai Chi because we study the peer-reviewed literature on the health benefits of taiji and qigong. And in order to study the literature, the students need a basic foundation in research methodologies and critical thinking for science. So complex multi-component interventions initially describes Tai Chi, and when I get to the alternative model, to the gold standard model for research evaluation, the complex multi-component intervention paper that we use applies to Tai Chi, but equine-assisted learning, of course, is also a complex multi-component intervention. As we go along, I'm going to make frequent comparisons to research. The simplest form of research that uses a pill, a single ingredient pill, like penicillin. And I'll make the point early and often that there's no such thing as horsacillin, because horses are not single ingredient interventions. They have multiple variables. They are complex, multivariable organisms, as are the practitioners, as are our clients and patients. So in the research paradigm, this is a simplification, obviously, possibly oversimplification. We have the objective findings, and objective is in quotes because there's no real such thing as perfect objectivity, but we approach objectivity with our quantitative objective attempts at being objective. So in interventional studies, we have the Western gold standard for randomized clinical trials, which I'll get to in a moment. And we have observational studies such as market research. If you're Apple, you come to Stanford and you say, how many students have iPhones? And you get a number like 20,000. And so that's observational, but it's also quantitative and fairly objective. Obviously, people self-report what kind of phone they have, but there's not a lot of subjectivity in reporting what kind of phone you have. And then we have subjective methods that are phenomenological, looking at the lived experiences of people. And most of our work in equine-assisted learning and therapy are phenomenological. We go by our experience and how our horses react and how our clients react. And there's not a lot of research that supports best practices for any given model. That's where HHRF will hopefully come in. It's going to be very, very hard to control for phenomenological effects because of all the variables involved. And then we have some hybrid models. The ethnographic sociological are a mix of objective and subjective studies and recording and observations. And we have the Bagua model, which I will get into. That's our alternative to the gold standard model. And we'll talk about that in a few minutes. So obviously, objectivity is part of the gold standard. And there's a hierarchy of objectivity in science, where at the top we have the really hard sciences like physics and chemistry. And then we start getting into the medical sciences. Surgery is a little bit more objective. You have a lump, you cut it out, and it's out, and you can measure that it's out, and you can see that it's out. You can see on X-ray and MRI and CAT scans and things that it's out. So that science is a little bit harder, and you can measure the results of taking lumps out and putting lumps in, like in the case of breast surgery, breast enlargement. And then you have internal medicine, which starts to be a little bit of a softer science. There are multiple components to internal medicine besides whatever is administered internally. And there you start to get into factors like bedside manner, um, some other variables in the way that people take their medicine. People don't take their own lumps out, but they take their own pills. So then you start introducing variables, and then you're kind of softening the science. Uh, and you have the placebo effect starting to enter in. There's a huge and very exciting placebo project going on at Harvard. And it turns out the placebo effect isn't just the placebo effect, the way we think of it. Oh, that's just placebo. It's a very, very important effect that has to do with beliefs and expectations and interpersonal relationships in the healer patient relationship. When I was in medical school, there was one of my classmates had worked at Eli Lilly pharmaceutical company before medical school doing drug research. And he said they had a blacklist of doctors who were big placebo responders. Their patients were placebo responders. They did well no matter what you gave them, because these physicians presumably had excellent bedside manner. So Lilly blacklisted these physicians because, a drug company wants to show a statistically significant difference between the placebo and their pill. And if you have physicians who are big placebo responders, you're not going to be able to generate that statistically significant difference and sell your product. So these physicians were blacklisted. And then you have psychiatry, which has some research, has some studies that you can do, but if you compare it to studying quantum physics, it's softer as a science. And at the bottom of the hierarchy, you have psychology, which is really hard to study objectively because of all the factors involved in the different measurements. Psychiatry has largely become a practice of giving medications. People go to psychiatrists to get drugs and psychologists to get help. Kind of, you don't have a lot of psychiatrists who really do good therapy anymore. But so this is kind of the meat of what we're talking about. This is the gold standard criteria for doing research that has predictive value. What we're after with all these factors is the predictive value of the study. If you do a study with a pill, you want to know that your study will transfer to other groups of people that were in your study. And so you want to meet these criteria to have the best chance of raising the predictive value of your study. So you want to have a large N, and large is the number needed to generate statistical significance, given your other methods. You want to have a long-term study. Long, again, is relative. Most taiji studies are 12 weeks. I think the EAL studies are about that long too, certainly not much longer than 6 months. The one of the most famous really long-term studies is the Framingham study in Massachusetts that looks at multiple risk factors for heart disease in a huge population of Framingham, Massachusetts, and I think it's been going on since the 1950s. Boy, is that true? 50, 70? It's a really long study. I'll mention here that when I started at Stanford, I started out in cardiovascular research, the Mr. Fit type studies, multiple risk factor intervention trials. So my research background came early on at Stanford. You want to have a prospective study. Prospective means that you start at a time zero and you do an intervention and then you look at the results at some time in the future. The studies I was involved in went on for 2 years for each participant, looking at endpoints like arterial blockage on arteriogram. Compare that with a retrospective study is a study looking at medical records. For instance, the first indication that smoking was bad for the heart, the first studied indication was that people looking at medical records, looking back at medical records, seeing how many smokers developed cardiovascular disease, heart attacks, and strokes compared to non-smokers. You want to have control groups. So in the simplest case, with a pill, you want to have somebody taking a pill and somebody taking the active pill and somebody taking the sugar pill or placebo. And without getting into the findings of the Harvard group, let's assume that the placebo has virtually no effect. So you want a group where you're going to see an effect and a group where you predictably won't see an effect. So there you have the active drug versus the placebo. You want your study to be randomized, meaning that the assignation to the active drug group versus the placebo group is a random process. People don't get to choose which group they're in. The participants don't get to choose, and the researchers don't get to choose. Most studies use a computerized random number generator to randomize patients. And it comes out in an envelope. I remember doing heart attack studies for early treatment of heart attack in the emergency room. People literally were given an envelope if they agreed to the study. Okay, you're in this group. You're in group A, you're in group B. You want the study to be double blind, meaning neither the researchers nor the participants know who got the active drug or who got the placebo, nor do the evaluators know or the statisticians know. And you can start to see the problems with this and doing equine-assisted learning research, in that how are you going to blind somebody to the fact that they have a horse, and what's the placebo version of a horse? So think about EAL as we go through these criteria. So you want to have one independent variable. The independent variable is the intervention or the treatment. So in the case of the penicillin pill, it's penicillin. You have one active ingredient. And then you have in the case of penicillin, it's easy because you basically have one outcome too. Did the infection go away? I've put appropriate testing in bold gold here because that can be a real bugaboo. I know in Tai Chi research, they sometimes do tests that don't really test what Tai Chi does. And it doesn't happen so much in other kinds of research. It's pretty clear what outcome you're testing for. But there are side effects. Think of EAL. There are a lot of side effects that aren't expected and that aren't tested for, which may indicate the benefit of the intervention, but aren't tested for. So you can do the wrong kind of testing. You can do not enough testing. something to think about. And you don't see that addressed in the method section or the discussion section of a research paper. So ideally, you want it to be quantitative. You want to generate numbers. So a Likert test, the scale from 1 to 5. On the scale of 1 to 5, how well did you enjoy your breakfast this morning? So that's pretty quantitative, but it's not objective. That is a subjective but quantitative measurement. An objective measurement uses preferably something that's not the human observational capacity. So in the ideal case, it's a blood test, for example, that you can run through a machine. So you take a blood sample, you run it through the machine. Oh, my blood sugar is 90. And you get a both quantitative and objective measure. Ideally, you'd like to show a dose response curve for the intervention. The dose response curve says that as you increase the dose of something, you increase the response. So think of the example of caffeine. If you had 1 cup of coffee, your heart rate will go from 72 to 82. And if you have 2 cups, it'll go from 82 to 92, and so on. So what do we imagine that a dose of equine-assisted learning, psychotherapy, and I also include usually therapeutic riding and somatic horsemanship. So you can kind of see it as the minutes per day, days per week, weeks per year, years that somebody's in therapy. And then the response is the reduction in symptoms that you're measuring. Stress, spasticity, tension. I think there was an elegant study a few years ago, Pebbles, you might know, uh, where they did goniometer measurements on X-rays of children who had been in therapeutic riding. Do you know what I'm talking about?
I don't off the top of my head. I'm not sure if there's some researchers on the call that might.
It was an HHRF funded study.
Oh,
Yep. I'm 92.7% sure that it was, but it was many years ago. So yeah, it was a real interesting study. So
hmm.
most importantly, or yeah, pretty much most importantly, you want your study to be replicable theoretically by any set of researchers under the same methods that you've used. And here again, we can see the problem with equine-assisted activities where you can't have the same horses and you can't have the same therapists and you can't have the same participants over and over again. So that's a real problem. In Tai Chi research, one of the problems we have is that the researchers don't describe the kind of Tai Chi they're using. There are all kinds of forms in Tai Chi named after the families. There's Chan and Yang and Wu and Woo Woo. And if you don't say exactly what you did, then your study can't be replicated. So that's the gold standard for having a study that can successfully predict similar outcomes, hopefully beneficial outcomes in more types of groups of people than are in the study. Are there any questions so far? I I can't see the chat.
There are none in the chat at this
Okay.
point in time.
Okay. So now we get into our alternative model. This is a model that comes out of Harvard again. Peter Wayne is a researcher, wonderful researcher at the Beth Israel Hospital, also a Tai Chi instructor for many, many years. I've been to his Tai Chi classes in Cambridge, Massachusetts. And his textbook is the Harvard Medical School Guide to Tai Chi, which is our textbook for Stanford Medical Tai Chi. And the local angle for Ted Kapchuk is that I went to undergrad with him at Columbia, and he is also an acupuncturist. And he's the head of the placebo project at Harvard currently. So Peter, Wayne and Kapchick have this model called the Bagua model. Ba means 8, and Gua is the trigrams, and it's kind of culturally named after the fact that in Chinese culture, 8 is a very lucky number. You see a lot of Chinese businesses with the phone number something 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 8888. And this trigram is a fundamental element of ancient Chinese philosophy, including Taoism and Confucianism. When these trigrams are multiplied into all possible combinations, you have 64 hexagrams that form the basis of the I Ching, which is a divination system to not necessarily tell the future, but create a psychological map of the question under consideration. So in this Bagua model, there are actually 8 active ingredients of taiji. And if you look around the circle at the ones in bold, you can probably agree that these are also ingredients of equine-assisted learning and various therapies. And these aren't always measured for in to the extent that we do studies on EALP. I'm going to, well, EAAT, that term has fallen into disfavor, equine-assisted activities and therapies, but I really like that term, and I'm the mommy here, so so these are all active ingredients. I grade out aerobic exercise and musculoskeletal strengthening because, at least in my practice, that's not, other than the fact that people have to walk a quarter mile to the horses sometimes, that's not, I don't think that's a big factor in EAAT, equine activities. But, to substitute for that, as I'm thinking about it now, I haven't really thought of this before. This is hot off the press, hot off my brain. I think what I would substitute for that is just being outdoors. So there's an element of nature therapy in there. One of the points about these active ingredients is that when you're doing studies of taiji or equine activities, you need to control for all 8. There are probably more than 8. It was just Wayne and Kapchick just conveniently listed these 8 to follow the Chinese tradition of Bagua. You could probably find more, but if you find more, you would need to have a control group for each of these elements. So if you look at something like awareness, mindfulness, and focused attention, let me ask you guys, and I can't see you because I just have my screen up. Let me ask you guys, what kind of intervention would you use to control for awareness, mindfulness, and focused attention? Nobody? Anybody?
And you can come off mute if you'd like to answer.
Sorry?
I was telling them they can come off mute if they'd love to answer that
Oh
question.
yeah, unmute, because if you needed to have an intervention, a mindfulness intervention to tease out that element of equine-assisted learning, maybe a big benefit of equine-assisted activities is just people becoming more mindful during the activity and in their lives. So what would you use as a control group that just looks at mindfulness and focused attention?
You mean like an activity? Is that what you're looking
An
for?
activity. What activity could you assign to a control group that would be just about awareness, mindfulness, and focused attention?
Maybe even haltering a horse.
Well, forget about horses.
Oh, okay.
You know, once you introduce horses, you've introduced too many variables. We want to tease out, we want to have as few variables as we can. So what's an activity with very few, almost no variables? I mean, all activities have variables, but what activity would you use for mindfulness, focused attention, and awareness?
We have meditation
Yes,
and chat.
absolutely. So get somebody that does Headspace or you know, one of the heart math apps or something like that. So compare, so that would be one of your control groups. Because if you're doing EAL, you have to have a control group for all of these. For nature therapy, which I'm substituting for aerobic exercise, you would have somebody that just takes a walk in nature and see what groups come close to the results you get with you know, with the horses. Do any of these groups come close to having the results you see with horses, such that you can say, oh, well, it's not the horse, it's the mindfulness. Oh, well, it's not the horse, it's the fact that the participant has the belief and intention that they're going to heal. And we can talk more about that later. So the meta level questioning of all these scientific models is it possible to conduct a gold standard study on EAL, et cetera? Given all the criteria and all the variables in EAL, I would say it's not. But, you know, this is something for you to think about. Is it necessary to have gold standard studies to prove that what we do works? Do we need heart rate variability? Do we need measures of oxytocin and dopamine and cortisol? And do we need polyvagal therapy to justify what we do? And do we need FNIRS to practice what we do? Are these at the point where they can inform our practices? And here we get back to the phenomenological models. If at the end of the day, we can do these studies, how do they address or fail to address our own personal experiences of these therapies, both as practitioners and the horse-human relationship when we go to our horses, when we groom our horses, when we talk to our horses, when we lead our horses, when we ride our horses? How does our personal experience, how do the studies describe or not describe our personal experiences? And how do we address pseudoscientific reasoning? I think we're seeing a lot of that, especially this week. And without getting too political, let's see. So I know that, before I get to that, I know that at least early on, when I was following the research committee of EGALA, say, trying to come up with standard terminology, trying to come up with gold standard research. I know that there were basically two motivations. One was to develop best practices, and the other was to get justification and validation so that insurance companies would reimburse our sessions. And so I came up with this insured wedding analogy, which is that if insurance companies would cover weddings, will your insurance company cover your wedding if you can prove your love? And if so, what tests will they use? And so we have to ask, is EAL more like a pill where the insurance company, your pharmaceutical plan, your health insurance will cover the pill, or more like love, where the wedding insurers aren't too sure how to prove anything? This is a little bit off the wall, but I think that when we think about what we're proving with our research, we need to know that there's a lot about what we do that can't be proven. I personally have never wanted to do research on my programs. but I won't go into that now. Let's go. So some of the philosophical questions, which have now become philosophical and political questions, are: what is science anyway? What is truth? What is it? Is there a global standard for science and truth? Or are there individual standards? What constitutes proof or truth for you? And it's different for different people, as I'll show you on the next slide. What constitutes proof for the masses this week when we're hearing about Tylenol and autism? So if we look at Carl Jung, who actually got a lot of his theory from ancient alchemists who assigned different human qualities and functionality to the four or five elements. The ways that we arbitrate truth, the arbiters of our truth, are certainly the intellectual, which is what the gold standard for medical research appeals to. That's a thoroughly intellectual basis for judging the validity of studies. There's somatosensory, which is more phenomenological. Does something make us feel good? There's the intuitive or the relational. If a friend of ours took penicillin and got better, do we trust that enough to take it ourselves, or ivermectin or bleach or whatever? But most of our truth testing is done, and the way we vote in elections is done on an emotional basis. No matter how we try to rationalize our decisions by claiming they're intellectual, there's just a huge emotional component that may be hidden to us. Um, so this is how we and other people judge truth. And it's a question of how you want to design your studies, whether you want to try to make them as intellectual as possible and eliminate these other inputs. And I think that for equine-assisted learning, and certainly for taiji, you cannot isolate these four contributors to truth testing and epistemology. So there we have it.
Thank you so much, Dr. Kane, for that presentation. We do have a comment in the chat. You were talking about, the golden standard for research and why we do that and should we do that. One of the comments was for replicability standpoint, specifically defining what a nature intervention is very important. So for example, I would say not all equine therapy is outdoors, some are indoors, and the natural world is multifaceted, and we focus on the interaction with sentient non-human beings. So Tina provided that comment in the chat. Thank you, Tina.
Yeah, thank you. My name's Tina. I'm Dr. Christina Grabowski. I was trained at Boston University in medical anthropology and worked globally on client-provider interaction, focusing on family planning counseling, and we focused on informed choice. And so I'm a mixed methods researcher, and so I'm really impressed with how you've laid out the Western model of science, and understanding qualitative and quantitative aspects of research design. I'm on ResearchGate, and one of the things that's really widely cited by researchers is in psychology and is health belief model. And I think some of what you're bringing up is related to the social construction of reality being different in different cultures. And I think that one area we could pursue is, what is the value from the perspective of the users, or the the participants as well, and how that help inform what variables we define to measure. Because I think whose reality counts is one of the sort of movements in the global public health field that I was in for many years. And so we really, I think, in terms of the inductive and the intuitive aspects, can try to understand from their perspective, why are they benefiting? How are they benefiting? And then try to create the indicators to kind of capture that. And I know that, like, I was funded by a National Science Foundation and Fulbright to do my research in Indonesia. But you know, one of the real strengths, I think, and why my studies from 1990 is still cited a lot, is the methods, and it's very you know, strong mix of quantitative and qualitative, and I think that that would really benefit our field in you know, in equine you know, measurement of um, understanding the sort of interaction between variables and the added value. Because, like, for example, as a you could have as a control, in a way, Tai Chi, and then Tai Chi plus horses, and try to see,
Yeah.
you know, what's the added value of that
Yeah.
sentient being interaction.
Well, come on over to Stanford, Tina, and we'll do that. We'll do a study. But yeah, no, does anybody else want to unmute and respond to Tina before I say something? Tina, thank you so much for that. That was really well put. And I have to point out the contrast between the weekend I spent at Warwick Schiller. I don't know if some of you know him. The Marcy's shaking her head violently, nodding violently. So we were at his retreat on his huge ranch, huge, gorgeous ranch out in nature, where two of my co-presenters were Native American women who, one was Lakota and one Hoopa from Oregon, who talked about the ceremonies in their cultures where people just accept at face value the benefit of these ceremonies to health and well-being, and versus the world that I've just described, where you have to come up with all these measurements. And Tina, um, I haven't done a deep dive into the findings of the placebo project at Harvard, but I know that a big component of the placebo effect that seems to percolate into positive results in many studies is belief and intention. You know, it's just what you're saying. What is the value? What does the participant believe is the value? For him or her or them, or of the test. And one of the studies that we use in our journal club, which is actually my favorite study of breathing and coordinated breathing and muscle movement, uses a standardized test for expectation. Before they do the intervention, they actually measure the participant's expectation of results. So there are, you probably knew this, there are standardized tests of expectation, and that is a huge component in results. And I love your idea of doing horses with Tai Chi or qigong and horses without. That would be a nice study, I think. With FNIRS or something. No, I don't know. I don't think we need FNIRS. We don't know enough about how to interpret FNIRS data to correlate it with best practices and you know, as you say, with the desire for the participants.
Do we have additional questions or comments?
I'm really interested in this whole placebo effect, what you're talking about with the doctors who are actually more positive. That to me sounds really interesting. Like, is it really mind over matter, and how much the mind has over the body?
The mind has a lot of power over the body. There are, I think, 97, I can't remember if it's 37, probably more like 37 documented miracles from Lourdes where they've, um, looked at medical records, done tests on the people claiming to have been miraculously cured. There are thousands of claims of miracle cures from the waters at Lourdes, but 37 documented cases. And there are anecdotal reports of unexpected, I don't want to call them miracle healings, but that's probably what they are, and unexpected healings, even in my experience, from people meditating. One of our chief examples in Tai Chi, we do something called Guolin walking. And Guolin was a woman who had ovarian cancer in the 70s, and there was really nothing for her. She was in Beijing, and even as far as Beijing had the most advanced medical care in those days, comparable to our best medical care, there was nothing for her, and they gave her 8 months to live. So she went to her grandmother, who was an herbalist and a qigong practitioner, and she did qigong 4 to 6 hours a day. She developed her own technique, her own practice, which is now called Guolin walking, and she lived 10 more years. So the Chinese government is looking at those at Guolin walking, also um, something called the Baduanjia and two other Qigong type forms, and finding enormous benefits with people in with cancer, not predominantly for survival, but also pain, depression, and appetite. But those placebo responders that Eli Lilly blacklisted, that was all about the relationship. Those were people who had great bedside manner. And I don't know how you measured it, but they knew somehow that those physicians were getting two good results from the sugar pills. Um, yeah, and I think, as I say, I haven't done a deep dive into the results of the placebo project, but I know that belief and intention and mind over matter has a lot to do with it, with who
But
gets better.
it would be great to, because you talk about, I mean, people talk about, well, if you set your mind to it or if you're
Mhm.
positive, but people were like, oh, that's a bunch of phooey. I don't believe
Yeah,
it.
yeah,
But it does make a whole,
mhm,
like if you set your intention and
yeah.
really focus on that. I totally agree with it. But, having that proof would be great to really show people, yeah, this really does work. I mean,
Yeah.
put,
Well, then you get into, well, what is proof for people? Because,
yeah.
part of my, yeah, I mean, you can give people data up the wazoo and they're still not gonna believe. You know, Honestly, my background is in parapsychology research. Um, and I know scrupulous researchers at Duke and out here in California, formerly with the SRI, which was the Stanford Research Institute, who have done airtight remote viewing studies, airtight extrasensory perception studies. There's a guy out here doing unbelievable studies on how the body precognitively can sense stimuli. I won't go into it, but it's Dean Radin, if anybody's interested. And it's been replicated in earthworms and Bengalese finches. And I'd love to see something in horses. But then you have somebody like Martin Gardner, who was formerly the editor of Scientific American, and he did not believe in extrasensory perception, and he said, it's not true because it can't be true. hello, what kind of statement is that? That, people a priori reject out of hand a lot of these beliefs and practices that they just can't get their heads around. And I don't see spending a lot of time trying to convince the unconvincible. The question is what is going to make us better practitioners? What is going to make us healthier? Um, and it's not, we don't got to show no stinking badges.
This is Tina again. I just wanted to add too that like what you're talking about is compassion, self-compassion, empathy,
Yeah.
and trust. And those are all things that I think the interaction, with horses is bringing out that, you've measured that it improves counseling or interaction with others, and in the patient doctor relationship. There are a lot of power relationships in all
Mm-hmm.
cultures, and I think
Mm-hmm.
that is really helpful for for that purpose of understanding the vulnerabilities of others, how to relate to it. And for some people, it takes their own illness for them to become ill to really understand, oh, well, I can empathize with this other person feeling vulnerable. But, in absence of that, it's such an opportunity to, experience being vulnerable for somebody who's going to be in a position of power as a doctor, to experience that.
Mm-hmm. Yeah.
All right. Well, her time has come to the end.
Turn into a pumpkin.
Yeah. Deborah, is there any other questions in the chat, or we need
I
to?
do not see additional questions, just a few comments. We'd love to hear more about your books and your manuals. And just thank you very much. Very helpful and encouraging. And thank you
Thank you.
so much.
Books and manuals on Etsy of all places. So,
Perfect. Thank you for
and
that.
Amazon. Yeah. Etsy and Amazon. Thank you.
Yeah, we've enjoyed
Thank
your
you, Pebbles. Thank you,
presentation.
Deborah.
Thank you for
Thank you.
being here. Appreciate it.
Have a great autumn.
Yeah.
Bye-bye.
Bye.